form of secondary glaucomas which is known to be very challenging to actually, and we need to know. We need to know, and this is, the picture that usually ended with patients with uveitic glaucoma, either changes in the trabecular shock itself or in the morphological changes. So we need to know what makes or the changes lead to these changes in the eye, or the inflammatory condition lead to these changes in the eye. We know glaucoma is relatively a common and serious complication of uveitis. And despite of the improvement in the medical therapy of the disease, both the glaucoma as well as the uveitis, still its management is difficult to deal with, the management of a glaucoma. The condition described by first time in the early in the 19th century described by Joseph Peer, about 200 or more than 200 years ago. He was the first one to report association between uveitis and glaucoma when he described a case with arthritic iritis, then followed by glaucoma and blindness. Then the reports start to come over from Dismas and Mackenzie's and others. So he is credited for the development or the description of this disease. The prevalence of the disease, when you look to the literature, you find it's up to 20% of patients that have the uveitis develop some sort of secondary glaucoma. And they found Neri and his colleagues in a series of about 390 cases or more that the incidence of the disease or the glaucoma increases with the chronicity of the disease, being 6.6 or around 6% within 1 year from the diagnosis of the disease, and which goes up to more than 22% after 10 years. And they said that from their series that the incidence of glaucoma was similar among different types of uveitis, anterior, posterior, etiologic, regardless of the etiology and so on. But others have a different opinion. Takahashi from Japan, he reported a larger series, about 1,600 eyes or more, and he said that, or the group said that, the incidence of glaucoma is more common in certain types of uveitis, like sarcoidosis being the most common type of uveitis that can lead to secondary glaucoma, followed by herpetic anterior uveitis. Also, in our area here, الربيعي أو اسمه الربيعي ولا الربيعة ولا الربيعي, our colleague 2 years ago, Okay, so he reported, there is another report also more recent than this, which is that we're having a more number of patients. They reported that the glaucoma is more common in HLB27 positive anterior uveitis, followed by juvenile idiopathic arteritis, Fox-Koeniger disease, and so on. So what we want to say here that yes, it is not, the incidence of a glaucoma is not similar among different types of uveitis. The racial as well as the geographical factors playing a role in the incidence of uveitis. So we need to keep this in mind. And the elevation of intraocular pressure in patients with uveitis has been classified in two types: the inflammatory ocular hypertension syndrome and the secondary glaucoma. In inflammatory ocular hypertension syndrome, 25 of patients with high pressure classified to have this type of, of elevation of the pressure, اللي هو inflammatory ocular hypertension syndrome, which is transient usually. Doesn't last long, short duration. And most of the time is self-limited and without leaving, whether you treat or not, but most of the time we treat, without leaving any glaucomatous visual optic disc changes or visual field changes. And it is associated with the onset of the inflammation. Most of the time it's associated with the onset of the inflammation. And in fact, the occurrence of this inflammatory ocular hypertension syndrome is strongly suggestive of infectious etiology. It has been, or it has been reported with uveitic, toxoplasmic, as well as syphilitic uveitis. And based on that, in fact, they said, or the authorities in this area, in uveitis, they said once you have such a pressure or such type of inflammatory ocular hypertension syndrome, you have to think or believe that there is an infectious etiology until proven otherwise. So inflammatory ocular hypertension syndrome most of the time helps you in reaching the underlying pathology, which is most of the time is infectious. The treatment of this is usually we treat the underlying pathology. Yes, you may give short or anti-glaucoma medication for short time, but the main treatment is to go and treat the infectious etiology. And actually, we have little experience in one of the, the Boston-Schwarzman syndrome or glaucomatous cyclitic crisis, which has been followed or given this name for many, many years. And we followed, I have experience of 4 patients, which comes to me and with episodes 3-4 times a year. And then one time, 2 of them, they presented to me with a focal corneal edema, which I'm not used to. And corresponding to that corneal edema, there was a keratical precipitate. I took the patient to our international figure, Prof. Asrar, and said, this is not the usual presentation of Boston-Schwarzman syndrome. He said, no, this is most likely nowadays, they call it cytomegalovirus uveitis, and he treated him with, or them with, systemic antiviral agent, ganciclovir, and these things, you know it better than me. And honestly, the patients didn't develop any further attacks. We followed them for good or significant time. They didn't develop any inflammation or even a spike of pressure after that. So nowadays, they are probably the Boston-Schwarzman syndrome or glaucomatous cyclitic crisis is going to be they're given a better name, which is cytomegalovirus infection or uveitis or keratouveitis, which really indicates the underlying pathology. Secondary glaucoma developed in 19 patients of uveitic patients present with high pressure. And it is severe, really. When it occurs, it's severe type of secondary glaucoma. And in most of the time, patients with secondary glaucoma, they need both medical and surgical intervention to save or to prevent further damage to the visual parameters. Again, those with secondary glaucoma, up to 13% of them, they ended with worse visual prognosis and even blindness. So patient getting visual impairment and blindness because of the complication of the uveitis. Among these complications is the glaucoma. There are many risk factors for elevated intraocular pressure that we need to keep it in our mind to pick up those who are at high risk to develop glaucoma. Age is a very important risk factor for development of elevated intraocular pressure. And we know uveitis is the disease of young and middle-aged patients, those who are young and in the 40s or less even. And so when it happens in old age group, like 60 or 70, they are at higher risk to develop high pressure. Do you know why? why they are at higher risk to develop high pressure when even they get a mild inflammation. Anyone can suggest why they are at higher risk? An old man developed mild uveitis, and he developed high pressure. Probably this mild uveitis or moderate uveitis, if it occurs in young, they don't develop uveitis. No suggestion, nothing you can pick up. What is it? This is it. Why, Iman? Very strange. So the function of trabecular meshwork declines with aging. So any insult to this system will unmask the function of trabecular meshwork and develop elevation of the intraocular pressure. So this is very important. Although it is the disease, such inflammation, if it occurs in young patients, probably will not develop the disease. Chronicity is another important risk factor. We know that we saw that the incidence of uveitis, of glaucoma and uveitis, it increases with chronicity of the disease. And this is reflect the cumulative effect of inflammation on trabecular meshwork, which we'll see a little bit later. So chronicity is another risk factor for development of secondary glaucoma. Corticosteroid, another risk factor for development. And we know that corticosteroids is a major or primary treatment for non-infectious uveitis, which are the majority, and the chronic use in a chronic patient of chronic use of steroids is well known to have or to alter the trabecular meshwork and add another insult to the trabecular meshwork that lead to elevation of the intraocular pressure. And we'll come to this again later on, to the effect of steroids on the trabecular meshwork. Severity, as I mentioned, severity, usually secondary glaucoma is highly frequent with severe diseases. And there are certain indices that can tell you this disease is severe. Among these is the presence of posterior synechiae. And the presence of posterior synechiae of patients with uveitis with posterior synechiae, 45% of them develop secondary glaucoma compared to 17% in those who are not having posterior synechiae. So posterior synechiae an indicative for the severity of the disease. So yes, severity is another risk factor for the development of secondary glaucoma, as well as patients with HLA-B27 positive uveitis. They have higher risk to develop secondary glaucoma, about 4-fold compared to HLA-B27 negative uveitis. So there are granulomatous uveitis and but these are a major risk factors indicating or indices indicating the severity of the disease. So patient with posterior synechiae, you will find him that he has secondary glaucoma, or he most likely will develop secondary glaucoma, so they need a more special care. So what is the pathogenesis of glaucoma in patients with uveitis? Of course, there are several mechanisms taking place in the anterior segment, in the aqueous humor, and in the anterior chamber angle. So there are biochemical and cellular changes in the aqueous position and its dynamics. And there again, we'll come to this. There again, there is a direct involvement. There are certain entities, as we mentioned probably earlier, certain entities that there is direct involvement of the trabecular meshwork, as well as corticosteroid effect on trabecular meshwork. And all of these together, either combination or some of them, they give a changes in the trabecular meshwork that lead to open angle glaucoma, which is the uveitic open angle glaucoma, or uveitic open angle glaucoma that is the most common type of glaucoma in uveitis. Other changes, like morphological changes, as we'll see later also, that will lead to another type of glaucoma, which is the angle closure glaucoma. So the changes in the anterior chamber and in the angle together in combination can lead to open angle glaucoma, which is the most common due to changes in the trabecular meshwork, or due to morphological changes in the anterior chamber angle that can lead to angle closure. So in biochemical change and aqueous composition, we know there are proteins, inflammatory in patients with uveitis, inflammatory cells, inflammatory mediators, and toxic agent. And we know protein is normal present. It's one of the contents of or composition of the aqueous humor. But normally, the concentration of protein is about 1% of its concentration in the serum. In uveitis, there is a breakdown of the aqueous blood barrier that lead to leak of proteins in the aqueous, and in severe cases, they found it to be resemble to its concentration in the serum. So you can imagine a plastic aqueous, there is no movement of the cells due to the high quantity of protein. So this definitely will lead to elevation of the intraocular pressure, either directly by aqueous sludging or embedding of the outer. It's a mud in the anterior chamber angle, or indirectly by see the coagulum. This is after treatment coagulum here of fibrin and inflammatory cells and whatever protein. This can also lead to posterior synechiae with formation of anterior synechiae and development of a bad and uveitic glaucoma. So this is the protein role in the uveitis patient regarding the uveitic glaucoma or the mechanism of uveitic glaucoma. Then it comes the inflammatory cells. This is one of that one and this one of our patient, and you see this is a VKH patient, and you see the inflammatory aggregate on the trabecular meshwork. This aggregate by itself can lead to mechanical or physical obstruction of the outflow facility. It is really mechanically can lead to elevation of the aqueous resistance, aqueous outflow resistance. This is directly, and indirectly, this aggregate or inflammatory aggregate release cytokines, infiltrate and trabecular meshwork and the Schlemm's canal and mechanical blockage. So indirectly by releasing inflammatory mediators and altering the trabecular meshwork cell size, function, and extracellular matrix, as we'll see it in a minute. So inflammatory aggregates can lead to the occlusion, physical occlusion of the trabecular meshwork, as well as by the releasing the inflammatory mediators and cytokines and so on, and lead to damage of the trabecular meshwork cells, and even enhance their migration away from the trabecular meshwork. And the end result is the increase the aqueous outflow resistance and elevation of the intraocular pressure. This is the end result. So these together can lead to elevation of the intraocular pressure. Then we come to inflammatory mediators, cytokines, and toxic agents like oxygen-free radicals and so on. But one of the cytokines is well studied is the interleukin-1. And the action of interleukin-1 in uveitic patient, it leads to activation of matrix metalloproteinases, especially metalloproteinase 3. This is well known to lead to degradation of extracellular matrix in the aqueous outflow pathway, especially the uveitic outflow. This will lead to increase in the uveitic outflow, which lead to drop of the pressure, and especially in acute cases. So this action of interleukin-1 will lead to degradation of extracellular matrix material, and in addition, in acute phases of uveitis, there is what? Say everybody, reduction of aqueous humor production up to 50%. And this has been shown in animal studies. So this reduction of production of aqueous humor by the inflamed ciliary body with the cytokines action on the extracellular matrix material in the outflow system, exactly in the UV scleral outflow. This will lead to a drop or subnormal intraocular pressure. Such events will lead to shifting of the aqueous, which sometimes lead the aqueous, the UV outflow route, outflow facility increases by 4-folds. This will shift the aqueous drainage from the main drainage system, which is the trabecular meshwork, to the UV scleral outflow. So once you give the treatment and this system goes back to its normal, the aqueous need to go or to be drained by the conventional route. But we know the conventional route in such situation has been divided from its nutrition, which is known that laboratory data says that if the trabecular meshwork not perfused at least by 1 microliter per minute, this will lead to the deleterious effect on the trabecular meshwork, cell death and migration and so on. So when the aqueous goes back, we'll find the outflow facility in the trabecular meshwork is changed. In addition to these cytokines, they have a direct adverse effect on trabecular meshwork, direct and cytotoxic, and stimulate migration, as we mentioned. So these together will lead to elevation of the intraocular pressure. This is a complex issue, but you need to know that in acute phase, there is a shifting of the aqueous humor drainage from the conventional pathway to the uveitic outflow, in addition to its reduction. So you will see a subnormal intraocular pressure. This occurs because of reduction, because of the action that occur, or the cytokines that taking place there, or increases in inflammatory conditions affecting the extracellular matrix and increasing the outflow system. In the UV scleral outflow, this will affect, has a drawback on the main outflow system, which lead to migration and death of the trabecular cells. So once the inflammation is controlled and the aqueous back to, or the UV scleral outflow cannot accommodate what was accommodating in acute phase, will go back to the trabecular meshwork normal or major drainage system. It will find it abnormal. So is it clear, or I need to? Yes. 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 Of course, this is a good question. We mentioned certain conditions that mainly those usually associated or due to infectious diseases, the presentation with high pressure. Okay? Presentation due to probably involvement of the trabecular meshwork, direct involvement of the trabecular meshwork. But majority, they usually present with hypo or subnormal pressure, and once you control the inflammation and due to the changes that we talked about and that affected or has deleterious effect on the conventional route, when the aqueous go back to be drained by its main system, we'll find the system is not anymore functioning as before. Good. Other thing is as we mentioned, direct involvement in of the trabecular meshwork, especially as we said in infectious conditions, such as Bosman-Schwarzman syndrome. Not anymore. It's nowadays they call it cytomegalovirus enterouveitis, and they gave you an examples of this condition, fuchsiouveitis, herpetic uveitis, as we mentioned, herpetic uveitis, as well as, for example, syphilitic, toxoplasmic. They are infectious diseases and usually associated with hypertensive or inflammatory ocular hypertensive type of pressure elevation. And then effects of corticosteroid. In normal eyes, when has been challenged by Armley and his colleagues long time ago to see the effect of corticosteroid in the trabecular meshwork, they challenged the trabecular meshwork with topical steroid, I think dexamethasone or prednisolone acetate or so, for 4 to 6 weeks. And they came out with that. They found that 33% of normal population, they call them moderate responder because the pressure changed from baseline by 6 to 15 millimeter or less changes. I mean, for example, the pressure was 10. After 4 to 6 weeks, it became 10, 25, for example, or 20. And they call them a moderate responder within this short time, 4 to 6 weeks. And they say that there are certain population that are more sensitive to the corticosteroid. This is in normal eyes. And those, when you challenge the eyes with this topical steroid, the pressure goes about 15 millimeter mercury more than the baseline figure, clear. So, and they said again, in addition to that, and they call them high responder. And they said also, at the same time, there are certain segments of population who are more sensitive to steroid, like primary open glaucoma patients and their relatives, as well as children. Children, that again, has been reported in many reports that they are more sensitive to dexamethasone, and they usually respond, or the pressure respond to dexamethasone, whether topical or in the skin creams or whatever, more rapid than adult patients. So you need to pay attention. So this is a normal population. And patient with, and what's the mechanism of that? How the corticosteroid lead to pressure elevation in normal and abnormal, of course. It usually associated with, the phagocytosis theory, as well as the glucosaminoglycan theory, and so on. So this leads to alteration of cell size, as well as skeletal organization and extracellular matrix deposition. And we said a while ago, in inflammation, there is a degradation of extracellular matrix. When you give a steroid, you stop the prostaglandin and the cytokines and so on. So will be a more deposition of this extracellular matrix. So the end result is changes in the trabecular meshwork that lead to increase in the outflow facility and increase in the outflow resistance and elevation of the intraocular pressure. So the structural changes in the anterior chamber, either microscopic or macroscopic. Macroscopic, what do we mean? That the angle is open. When you look to the angle, you find it open, but there are changes in the mechanical blockage of the outflow pathway, clinical inflammatory damage to the outflow pathways, involvement of the trabecular meshwork, and the steroid effect. So this will give an open angle type of secondary glaucoma related to uveitis. Or these changes lead to morphologic changes, or macroscopic. So the disease, there is a posterior synechiae, or even presence of such a inflammatory precipitate can bridge the iris to the trabecular meshwork without a biliary block. These are two of our patients. This is ankylosing spondylitis. I was following this patient when I was a resident, and this is probably 3-4 years. Took a picture, and we have many of these. This is a VKH, and you see the aggregates here, and this can lead, especially in a population like our population, where there is the angle, or Asian, where the angle is not so wide. So presence of this aggregate and the presence of high protein contents, this can bridge the iris, or the iris to the peripheral cornea, or to the anterior chamber angle, and cause direct peripheral anterior synechiae without iris Bombay. Okay? This is a posterior synechiae led to iris Bombay, and as you see, the morphological changes, some of them went back when we did multiple YAG iridotomies, but of course, this will not change the pressure. Pressure remained high, but we need to put the eye, regain the integrity as much as possible of the anterior segment. Okay, good. So what is the management? The management of this disease, any disease, it needs a proper evaluation. Especially in this disease, we need to, we are systematic. We need to take a good history, looking to the signs and symptoms, hopefully to find out the underlying pathology, and visual field to see how much the damage is occur in a patient with glaucoma. Uveitic glaucoma, slit lamp examination might give us some sort of or clues to the type of the disease. So knowing the disease, type of the, or the underlying pathology is a mandatory for a successful treatment. Gondioscopy also is very important to see what we are dealing with, what type of glaucoma we are dealing with. Are we dealing with an open angle or a closed angle? The management is totally different. And of course, fundus examination, again, to look for clues. I'm sure you are knowing these better than me, but also to estimate the damage from the glaucoma, if there's a glaucoma there, and the cup disc ratio, as well as nerve fiber layer. Sorry. And UBM also to study the ciliary body. Is there atrophy of ciliary body? And most of the time, in correct cases, you'll find the ciliary body, the ciliary processes are already gone, and sometimes you find, as that picture that I show you, Iris Bombay, and still the pressure is low because the production is affected dramatically. So this examination should take us, if we do it in a proper way, to the proper diagnosis that will be our exit or next step to tailor our treatment to manage this case or to manage the disease and to save the patient as much as possible from of his visual function. And again, one conception in the management, which is very important, that we need to keep it in mind, in our mind, that anything that you will do without proper controlling the inflammation, you are wasting your time and wasting the patient vision. So, under treating the inflammation or the uveitis with corticosteroid to minimize the elevation of the intraocular pressure, not evaluation, elevation. To minimize the IUB elevation, not evaluation. Okay? This is a mistake. At the expense of good control of inflammation, as many authorities, they say, it's a false economy. You are losing the eye. If you didn't lose it by glaucoma, you will lose it by inflammation. So it's a prerequisite for any successful management of uveitic glaucoma is to control the underlying pathology, to control the inflammation. Otherwise, as I told you, you are wasting your time and patient vision. So never ever say, okay, I will reduce the steroid to minimize the pressure. The pressure is not elevated only by the corticosteroids. Yes, it may be an additive effect, but there are other things that led to the pressure elevation, the changes in the anterior chamber angle, as well as morphological changes. So hitting the patient with heavy steroid is the clue for your success in managing the condition. And then you can deal with the side effects, if it is steroid or non-steroid. Once you control the inflammation, there are many ways to deal, to control the pressure. Treatment, of course, in the past we were saying about 70% of patients with uveitic glaucoma, they respond to medical therapy. I think nowadays, with more recent studies, about quarter or 30% of patients, they respond to medical treatment, and the rest, they need both medical and surgical treatment. And in our population of uveitis, which is one of the largest series worldwide, we found that almost 90% of them with uveitic glaucoma needed surgical intervention. So, yes, it's not as before. We said 30% of patients, they need probably medical and surgical intervention. No, the percentage is much more. So, and the treatment, first it started not but psychologic and not less than atropine. This is the main, very important tool to minimize the conversion or the development of glaucoma. If there is no glaucoma yet, and if there is a glaucoma, it's important to relax the ciliary body and so on, and to prevent formation of posterior synechiae again, if there is no posterior synechiae. Beta blockers is a major or first-line treatment. Adrenergic agonist, carbon inhibitor, whether systemic or topical. Prostaglandins. In the past, they said, okay, be careful when you prescribe prostaglandin in uveitic patient. And now recent reports, as long as the inflammation is controlled, there is no risk that it may aggravate or reactivate the inflammation. This is well-documented reports. Of course, we have to avoid myotics, because they are increased inflammation of the iris and ciliary body, and also might lead to formation or may lead to formation of posterior synechiae, especially in an abnormal contents of the anterior chamber. Even when you control the inflammation and the eye nerve cells, there is a flare, which is long life. There is already, the ocular-blood barrier has been broken. So the amount of protein in the anterior chamber is never ever to go back to normal. So using a pilocarpine may facilitate the formation of posterior synechiae. When we fail, which is frequent with secondary glaucoma, to manage it medically, of course, if there is iris bombay, as we saw in that patient, laser iridotomy is a must. Sometimes we do it more than one. If it is not or get close frequently, you need to go and do surgical iridectomies. And in my last experience, which is about 30 years or so, I don't remember that I did it surgical peripheral iridectomy more than one or twice. So most of the time, the laser is successful if you do it in multiple sessions and increase it and so on. In most cases, it will do the job. And laser trabecoplasty, if you look to the literature, you'll find that SLT, ALT, they might help in reducing the pressure. This is ineffective. I feel it is, probably I would say, as I will say with the other laser, I think it's contraindicated. You don't need it. The trabeculectomy and antimetabolites is the procedure of choice until now. It can help in all types of uveitic glaucoma, whether open angle or closed angle. So it is a very important tool in our hand to control the pressure, but it has something probably that will come to later to it. Non-penetrating deep sclerectomy, which is employed in the management of this disease over the last, probably I would say, maximum 2 decades. And we have a good experience, our facility, and as well as our colleague in this facility. So again, we'll come to it. Tube surgery, again, a very important alternative if the previous two, the trabeculectomy or the deep sclerectomy, are not a good candidate for this procedure. The next is the tube surgery. I know when you go to the literature, you will find many people saying that whether in a neovascular glaucoma or uveitic glaucoma, tube surgery is a very effective and so on. We don't believe from our experience, and if you go to the literature, you will find that it is not exactly what's going on. Then goniotomy, again, there are reports, but I don't think this is effective, and a lot of reports claiming or criticizing this procedure in uveitic glaucoma. Cyclophotocoagulation, definitely, at least in our practice, has no rule unless we exhausted everything. So otherwise, it has no rule. So when you go to trabeculectomy, as I told you, it has a good success rate, which is variable, up to 78% after 5 years. But we know the trabeculectomy in normal glaucoma patient without extra risk for these complications, hypotony, inflammation, cataracts, it's well known as a complication of trabeculectomy. So in patient with uveitic glaucoma, the patient is more vulnerable to have these complications. So we need to be very cautious and should be done in a more or with an experienced person to deal or to prepare the patient before the surgery and to have a better or probably care after post-operatively. Again, trabeculectomy, in a study from Japan, recent study, they compared the outcome of a trabeculectomy or the success rate in 100 patients with uveitic glaucoma and similar number of patients with open angle glaucoma, and they concluded, or they found that the trabeculectomy with mitomycin C was less effective in uveitic glaucoma than primary glaucoma. And not only that, but also they found that there is more need for cataract extraction in patients with the uveitic glaucoma following trabeculectomy than those with the primary glaucoma, 60% as far as I recall, versus 10%. So this is very important. So whatever you do, the complication of trabeculectomy or filtration surgery is there. When we come to the tube surgery, I left the non-penetrating as the last, so if there's time, I can share it with you. So uveitic tube surgery, uveitic glaucoma is another very important modality of treatment, especially in cases where, as I mentioned, not suitable for filtration surgery. I mean, deep hysterectomy or trabeculectomy. But it has a good success rate in the first year, but most of the reports, they've said that it declines the success rate with more follow-ups. Not only that, we know the complication of filtration surgery in general, penetrating surgery in general, but here, with the tube, there is unique complication related to the tube, which is corneal decompensation and tube occlusion and so on. So it is not the primary procedure of choice, at least in our practice. And there is a very important report, from the United States. They have 80 child with uveitis. I talked to you, Iman, and others yesterday about it. 80 child with uveitis. Some of them, they're having secondary glaucoma, I don't remember. 30 of them needed tube glaucoma surgery. So they did the tube surgery in 30 child. And they took the others as for comparison, as a control. And after a mean follow-up of 3 years, they found that the tube surgeries in children with uveitic glaucoma are independently associated with significant decrease in endothelial cell density. So imagine such a child in his first decade or second decade that his life expectancy is very long, presence of a tube, in addition to the possible failure, but also the presence of the tube is really having its effect on the other visual parameters, I mean, corneal endothelium and so on. There's something. Thank you very much. Shukran jazeel. Allah yahfaz. So we need to keep this in mind, that tube surgery, yes, in addition to the other problems, also it might affect. And we have it, we see it even in adult patients, especially in children. You are not going to put it in the sulcus or where. You will put it in the anterior chamber. Usually they are phakic. So when we put this tube in adult patients, and it is a little bit nearer to the cornea endothelium, after a year or less or more, you will see the changes or the endothelial cell damage, or even sometimes we see an corneal edema corresponding to the place of the tube. So keeping this in mind. So I will not discuss this. I disagree on the management of uveitic glaucoma in seeing eye with this modality. So in 5 minutes probably, so I can leave time for discussion, I will share with you our experience of employing deep hysterectomy, non-penetrating deep hysterectomy in our patient, uveitic patient with uveitic glaucoma. We have, of course, if you want to go and see, we have some input to the literature. In this regard, we have 33 eyes of 21 patients, majority of them females, and the age, as I said, it is a young age. Its mean age was 29, and the majority of cases was, or more than 50% are of VKH underlying etiology. So, and the mean IUB at presentation was 37 millimeter of mercury, and the visual acuity range from counting finger to 20/20. Gonioscopy, it's a must to be open at least in the superior angle. Otherwise, there is no place for deep hysterectomy. It's a must, a prerequisite that you have at least the superior angle is opened. And as I told you, majority of cases are of open angle type. And one eye was pseudophakic, and 2 eyes had previous surgery, one trabeculectomy and one, I think, trabeculectomy, another trabeculectomy, or tube surgery. This is long time. And the main medication was 3.2, and our rule or our habit in dealing with these cases that we have to have a well-controlled inflammation, but we don't wait 3 months, as literature says. When you look to the literature, it's a copy. 3 months after inflammation. No, we don't wait that time because the pressure is high and the inflammation is under good control, and fortunately we have an international figure in this entity and this specialty, so we are able to control the inflammation. And then once you decide the surgery, we give the patient hourly topical steroid for 1 week before surgery while he's awake. And again, in majority of cases, especially those posterior uveitis and so on, intravenous methylprednisolone, 3 doses 3 days before the surgery, and continue anti-glaucoma medication as well as a systemic medication, immunosuppressive and immuno whatever. So, and the technique is unique in all cases in all our group also there, and I'm sure my colleagues here doing the same thing, fornix-based conjunctival flap, and every case mitomycin C 0.2 milligram per ml for 2 minutes, and patient, if there is, at that time we were using implant, Ibrahim, he preceded us, he said there is no difference between using implant or not, but we feel that it is better. But later on we found again if you use healing under the flap it can give the same thing, so we stop using implants. This is just a short for those who are not familiar with the procedure. It is a very short video, so it's large superficial flap, and then the second flap we leave a shoulder here in case we perforate it. I don't know. Then when we start this deep flap, we almost go to the choroid. So come on. So we need we know the dissection plane. Very strange. This is not on my computer. So once we open the Schlemm's canal, you see the aqueous start to ooze from there, and will ooze more when we remove. When we remove the floor of the Schlemm's canal, and this is peeling. I'm peeling the floor of the trabecular meshwork here. What goes with the what is Isra is not here, huh? Dr. Isra, okay. What we are removing with the floor of Schlemm's canal? What we are removing? Huh? Nobody knows. What is the? Huh? Yes. Who said that? Yes, we need to know the anatomy of what we are dealing for them. So we also remove the juxtacanalicular meshwork. So, and when you concentrate here, you will see usually transparent the floor of the Schlemm's canal and open angle glaucoma. But here, I don't know if it's going to be clear or not. You will see it. There is a pigment and deposit on the floor of Schlemm's canal. Is it clear? See, visible? Anyhow. So this is what is happening in the uveitic glaucoma. Then we extend the trabecular window, and then we cut the Schlemm's canal, the deep flap, and then we put either implant or healing or whatever, and close loosely. So postoperative care is again similar, continuation of maintenance dose of immunosuppressive agent and hourly steroids and topical antibiotic, and frequent visits, because additional intervention were needed or usually needed in these cases, whether subconjunctival mitomycin C, or the most important thing, and I think it's a part of the procedure, which is the goniopuncture. And our criteria for success are pressure more than 6 and less than 22, and quality health success the same, less than 22. And after a mean follow-up, it's ranging from 1 year to 10 years, with a mean follow-up almost 4 years, the intraocular pressure reduced from 37 to 14, and the medication reduced from 3 to 0.4. And the complete success was achieved in 24 of 33 or 72, and the overall success rate about almost 94. These patients, as I told you last week, in neovascular glaucoma, they are taking much better care than ordinary glaucoma. They are having or carrying extra risk for failure and for other problems. So, and all the patients, only 2 patients, I think, yeah, there are 2 patients, the vision worsened due to either macular edema or progression of the cataract, and otherwise they maintain their pre-op vision. And all of them, after 22 months, the goniopuncture or any intervention that to what you call it, to save the bleb or to save the function, whether good puncture or so, done before the 22 months. And complication, short complication is similar exactly to ordinary glaucoma. Very important complication that is needed, that are needed not to happen, which is the shallow or flat chamber or exacerbation of inflammation. None of them. Believe me, next day you see little congestion at the surgical site, otherwise the anterior chamber is deep and has no inflammation. And again, cataract progressed in 9 cases. Probably this is, I don't think this is related to the procedure, it's an extraocular procedure, but some or most of these patients has element of lens opacity before surgery, and with these frequent steroids, they usually progress to some extent. Hypotonia maculopathy, in 1 case that persisted, that needed autologous injection twice, and now I'm following him probably now 12 years or so. Yeah, 12 years probably now. This has been reported a long time ago. And he has a very beautiful pressure, bleb, and vision of 20/20. So when we look at the literature, there are little or no much studies regarding the deep sclerectomy in this entity, because the entity is rare, relatively, and not everybody compensates by this procedure. So when we look to the qualified complete success, almost comparable, as well as overall success rate in different entities, different ethnic groups, different hands, which indicates or giving us a very important message that, yes, this procedure, whether regardless of the type of uveitis, regardless of the, as long as controlled, the surgeon, if it is meticulous surgeon, usually they give the same success rate or similar success rate, and none of these studies reported a visually devastating complication. This is very important, and we know the outcome in trabeculectomy or in tube surgery. But I'm not saying that they are bad procedures, but I think in our practice, if the angle is opened, we give the priority for deep sclerectomy, and then if it is not open, or there are risks, or there is not suitable for deep sclerectomy, we go for trabeculectomy. If not, we go for tube surgery. So what are the advantages? Yeah, of course, the deep sclerectomy is an extraocular procedure and has multi-filtration routes and is not depending on the bleb. This is one of our patients. You see the trabecular window, decompression space, conjunctival bleb, which is very low, not as usual in most cases, although we sometimes find patients with a vascular bleb or very risky bleb, but majority of them like this is not elevated and not severely avascular. And when you do gonioscopy, this is a pigmentary glaucoma, you see the area of filtration delineated, very well delineated here, trabecular window, and the route of filtration is, there are 3 main routes, which is the subconjunctival and intrascleral, and this has been proven by animal studies by the Rosen group, Mahmoud and his group. They found that presence of aqueous humor in the rabbit eyes and the decompression space enhance the body to form new uveal scleral veins and drain the decompression space. In addition, which I believe as others, that the main saw or the main drainage system is the uveal scleral or subchoroidal space. I don't be, sorry, yeah. Schlemm's canal is, this is the main route, I believe. The Schlemm's canal, they said that when you cut the Schlemm's canal, Schlemm's canal, you cut it and you remove the floor, you remove the roof. The ends, the aqueous and decompression space, it goes through the Schlemm's canal again and drained by normal drainage. But there is a lot of things about this possibility, so it is not a major route of filtration. What are the disadvantages of this? Is, of course, open-angle glaucoma only, employed in open-angle glaucoma, and this is the major disadvantage, need for surgery, need for frequent post-operative visits. But you cannot, overcome this issue, after say a month or 2 or 3, you can convert it, even if the pressure is okay, to a penetrating one. And the longer learning curve, I don't believe that it is a disadvantage. All the people that learned this issue, if you ask them, they said it wasn't, a big deal. Once you are very meticulous and skillful, like Dr. Jid'an, he stayed with me 2 days, or no, 2 cases, and I did the cases, you will learn it very well. So, in summary, yes, uveitic glaucoma is a common and serious complication of uveitis, and glaucoma should not be an obstacle for aggressive treatment of intraocular inflammation with steroids, and the controlling inflammation as a mandatory to the success of any procedure you do, whether trabeculectomy, tube surgery, or divasculectomy. And we, as others, have impression or believe that divasculectomy is ineffective with high safety profile and open angle uveitic glaucoma. I'll stop at this time. I'm sorry for taking a long time. Thank you very much. Any question? Same question given to me by a colleague last week in uveitic and neurovascular glaucoma. As I told you, any cyclodestructive procedure, I'm against any cyclodestructive procedure in any type of glaucoma unless, especially with these eyes. These eyes are, as I told you, they are sick eyes before glaucoma. So in a neovascular glaucoma and uveitic glaucoma, I will never consider cyclodestructive procedure, regardless the type of cyclodestructive procedure, unless there is no other things that I can do. Any other question? Okay, thank you very much.
Yeah, keep saying there's a problem. I'm not sure why, but let's open it.
Yeah, you can open it.
Where?
Excuse me.
There it is.
In
Yeah,
any
yeah.
folder here.
Okay, good. Okay, so, okay.
We'll play it from the flash disk.
Yes, and we'll play from flash from the middle point because it's part 2. Close.
That's it.
Very good.
Thanks. Shall we give them 2 minutes?
Sure. It's a little early still.
Good afternoon. Can you call? Bring the people from outside. Assalamu alaikum and good afternoon, everybody. Our speaker today needs no introduction. Professor Cooperman, who we've had the pleasure of receiving and inviting to KKISH today. For those who don't know Dr. Cooperman, he is a very well-known figure in the world of retina, and he really needs no introduction. However, for those who were not here this morning, please allow me to introduce Dr. Cooperman properly. Professor Cooperman is a Roger Steinert Professor at the University of California, Irvine, where he is the chair of the Department of Ophthalmology, the director of the Gavin Herbert Eye Institute, the vice chair of clinical research at that same department, as well as the vice chair of academic affairs of the same department. He's also professor at the Department of Biomedical Engineering at the Henry Samueli School of Engineering at the University of California at Irvine, and is the chief of the retina at that same department. Dr. Cooperman received his medical degree from the University of Miami School of Medicine. Then he went on to do a PhD in neuroscience from the California Institute of Technology, very well known. He did his fellowship in surgical and medical retina with Dr. Ronald Michaels and Bert Glazer, as well as currently, Dr. Robert Murphy, who still works there in Baltimore, Maryland. And then he also did a fellowship in uveitis and medical retina with Dr. Bill Freeman in California. Dr. Cooperman is a principal investigator or participant in over 100 unicentral and multicentral clinical trials, which have focused on evaluating treatment options for diabetic macular edema, diabetic retinopathy, age-related macular degeneration, as well as treatment for AIDS. And his research and clinical interests lie in the several areas, actually: in vitro assessment of drug toxicity, sustained release drug delivery to the posterior segment of the eye, evaluating new technologies for the treatment of retinal diseases, intravitreal pharmacokinetics and retinal pharmacology, chemical vitreolysis, retinal angiogenesis, and collateral damage caused by ocular photodynamic therapy. Dr. Cooperman is a very, very known speaker, and you will see today how nice it is to hear him speak. Actually, he has delivered over 640 presentations worldwide at major scientific meetings, and he has published over 185 papers in peer-reviewed journals, and has been invited to participate and write about 80 invited articles and book chapters. And he's a recipient of numerous awards and honors, and I will just mention a few. That is the Senior Honor Award of the American Society of Retinal Specialists, the American Academy of Ophthalmology Lifetime Achievement Award, which is the highest achievement award that the Academy delivers, the American Ophthalmological Society Award, in which the membership here is by nomination, and it's considered at one of the highest honors in American ophthalmology, and he has been always listed as one of the best doctors in America from 1996 until today. So please welcome Dr. Cooperman, and I'm sure that you will enjoy his lecture.
Thank you for the very kind introduction. So this morning I spoke for a bit, and I will review a little bit of the introduction. The notion being here is that I want to share with you ultimately in this second part of this extended lecture how I actually manage patients with diabetic macular edema. For those of you that weren't able to come this morning, I'll review a little bit about what I talked about, at least the role of inflammation in the development of diabetic macular edema. I also discussed steroid differentiation this morning, which I won't do this afternoon, except I will only in some peripheral fashion. But again, I will discuss in more detail the clinical trials, sort of the notion of how science has led me to interpret the clinical trials, which then has impacted how I actually manage patients. And I'll be very happy to address any questions as well. By way of financial disclosure, I am a consultant to Allergan, and I've done a number of clinical trials with them. I have been sponsored here by Allergan, but they did not have any role in my writing this. I did send them a PDF file so they could have it undergo compliance review, but otherwise they had no role in the development of this talk at all, and these are entirely my feelings and nothing to do with the company. So this is the first 3 slides I showed this morning, and then everything else will be new, some things that I didn't show this morning. But just to review a limited amount of the science of what goes behind diabetic macular edema, different than the other diseases we take care of. Inflammation plays a very important role. What we learned in our training is about the retinal capillary damage. That's kind of the first point we pay a lot of attention. Endothelial cell thickening and parasite dropout. But in fact, things start happening a lot sooner. Hyperglycemia creates oxidative stress, which causes local inflammation, that releases a lot of inflammatory mediators, including VEGF. And I also want to make it clear to those that weren't here this morning that VEGF is absolutely important, and I use VEGF as my primary agent. So I'm not trying to say anything different. What I do say is that based on the science and the clinical trials and evidence, I am more likely to switch earlier to another class of drugs, steroids in particular, than many other Americans, but probably not different than many Europeans. And when I do use steroids, I do prefer to use the dexamethasone implant because I think it is the safest and most controlled and most effective option. So that's kind of the summary of my position, but it is very much VEGF based. But again, the inflammatory mediators are released, the cytokines and chemokines, that results in chronic inflammation, neurodegeneration, then finally the retinal capillary damage that we know so well, leading to disruption of the blood-retinal barrier and the development of edema. Now I think these two slides are paired slides, an interesting study by Dong et al. That looked at anterior chamber levels of various cytokines. So it's anterior chamber, aqueous humor, not posterior segment vitreous, but nonetheless, you can see here that in the age-matched controls, about 100 of them, compared to diabetics, 136 of them, all these interleukin levels were much lower in the control than diabetics. MCP1, monocyte chemotactin protein, was much lower in non-diabetics and diabetics, and VEGF was massive, under 100 to around 1,000 in diabetics, and this is without regard to the level of retinopathy. Another slide that I showed this morning showed that in fact, if you then looked at those same patients, the Dong study et al., and looked at the actual level of retinopathy of the patients in that study, the diabetic patients, and scored their retinopathy from very low to very high, which is a surrogate measure of time. The lower the retinopathy, typically the less time they've had diabetes. The higher the level of retinopathy, typically the longer they've had it. So it's a surrogate measure of time. You can see that VEGF is always high. It went from under 100 in a non-diabetic to about 1,000, even with minimal to no retinopathy at 10, and didn't go up by very much. It rose a little bit, but not by much in patients with very advanced diabetic retinopathy. So it wasn't sensitive to either time or the level of retinopathy. It's as if it's a switch. It went from off to on. Off in a non-diabetic, on in a diabetic. From under 100 to over 1,000 or around 1,000 very rapidly. Conversely, if you look at the other inflammatory mediators, and we can look at monocyte chemotactin protein, it starts low at 250 and goes up to 1,630. So it rises dramatically over time or with higher levels of retinopathy. And this is true of all the other interleukins as well. Start low and go high. And these are statistically significant. So it tells us that VEGF is absolutely important. Every eye that has diabetic retinopathy has a lot of VEGF in it. But not every eye has a lot of the other inflammatory mediators. Some may have low levels of inflammatory mediators. Others may have high level of inflammatory mediators. And the last slide that I showed from this morning that highlights what this might mean and why I think the way I do is this very simple study by Sohn et al. 11 patients, bilateral diabetic macular edema. One eye received triamcinolone, the other eye bevacizumab. There was anterior chamber assessments, aqueous humor drawn, pre-injection, and then 1 month post-injection. And what was not surprising was everything on the left with triamcinolone. We know that it does a good job at lowering the inflammatory mediators. In this case, triamcinolone didn't do much for interleukin 8, and this is one of the hallmarks of steroids. Each steroid has a different profile of what it does, even though generally they quench the inflammatory mediators. Also not surprising was VEGF levels. We know that steroids are good, but not great VEGF inhibitors. It lowered it by 80%, though I would argue that dexamethasone, as I showed in the slide this morning, is a much better inhibitor of VEGF than triamcinolone is. But again, 80% reduction, so no surprises here. Also no surprise in this column under bevacizumab, the bottom line. We know that bevacizumab, along with ranibizumab and aflibercept, is a fantastic VEGF inhibitor. It reduces it by 99%. What is surprising is the rest of this table, that none of these other inflammatory mediators changed at all. You would think that if you did something, we know that VEGF is important, and if you reduce VEGF dramatically, that all these other inflammatory mediators would have some sort of response, upregulation, downregulation, some sort of awareness that VEGF had been changed, but in fact they didn't change at all. Minimal changes. And this cannot be explained by either being upstream or downstream. This seems like a separate pathway. We've looked at this carefully. So there is a VEGF-mediated pathway and an inflammatory-mediated pathway. So one could argue that there may be some eyes that have high VEGF levels and low inflammatory mediators, and they might be exquisitely sensitive to VEGF inhibition. But other eyes that have high VEGF levels and high other inflammatory mediators, that if you are only lowering VEGF levels, those other inflammatory mediators are not affected, as we see here, and that might explain why there is persistence of disease. And that might tell us something important, why we have a differential response. We know that not all of our patients respond to VEGF inhibition. Many do, the majority do. One could argue whether it's 25% that don't, up to 40%, some number in that range. It might vary based on clinic, again, or genotype. Again, as I commented this morning, I know that diabetes is very difficult here. I also similarly have, in Southern California, we have a lot of Hispanic patients, Vietnamese patients, patients that are Asian that have very difficult to manage diabetes. Maybe not as bad as here, but certainly much worse than a typical Caucasian practice in the East Coast of the United States, which has less of this, less bad diabetes. So I have similar problems that I have to manage. So again, I would say somewhere about a third of my patients have what is called a suboptimal response. So one can see here that from the paper by Susan Bresler, this is from the DRCR Protocol I. To remind you, this is a study some years ago now, probably 10 years ago, but it was the first of, in my mind, the new era of pharmacotherapy analyses or management of diabetic macular edema. There were 4 groups. One group got ranibizumab at the original dose, the 0.5 milligram dose. In the United States, ultimately for diabetes, 0.3 was approved, but this was all the 0.5 dose. Ranibizumab plus immediate laser, ranibizumab with deferred laser, and those with deferred laser typically never got the laser, or they got triamcinolone plus laser or laser alone. But if you looked at the roughly 50% of the patients that got ranibizumab, fully a half had a good response, but only that half. The other half in that study, 25% were labeled non-responders, another 25% were what we would consider suboptimal responders, early but inconsistent, slow and variable. I think this non-responder rate is extremely high. That's not typical for me, but that's what was reported in this study, again from the DRCR Protocol I. So this highlights that in well-controlled studies, we know that a large percentage of the patients will not necessarily have a robust or an adequate response to VEGF inhibition. And again, it may be explained potentially, and I'll show you some more data to support this, based on what I showed you of the science of inflammation, that VEGF inhibition does not affect the other inflammatory mediators, and the other inflammatory mediators rise over time, and if they're not treated, may be responsible for causing disease. So here's a study looking at steroids. So this is the fluocinolone acetonide implant, and you can see they're one of the real world, or one of the clinical trials, rules of thumb, so to speak, in the PRN studies is roughly 28% are going to be 3-line gainers. It's true study after study, with one exception, and that's DRCR Protocol T, which I will get to in this talk. But about 28% you'll see in many studies are 3-line gainers, so that's what we see in these 2 doses. In blue is the one that was approved, but the control group is what I find interesting, and particularly on the next slide. In the control group here was a sham control group, but what was allowed, everybody was masked, the patient, the treating physician, the observing physician was masked, the treating doctor was not. And if a patient did not have a good response within 6 weeks, you were allowed to treat at will. And this study, when this became available, when this study was being conducted, typically most patients ended up getting bevacizumab. And so this became a bit of a surrogate for bevacizumab, but some got triamcinolone, some got other things, but typically bevacizumab. But what was particularly interesting is the next slide, the subset analysis. What they did is they looked at the patients and looked at their duration of macular edema prior to enrollment. The median duration was roughly 2 years, 1.73 years. Let's consider it 2 years for argument's sake because it'll tie in with the next slide. And then they looked at those that had less chronic disease, less than 2 years, and those that had more chronic disease, more than 2 years, and looked at the response to therapy. And again, this one's blue. This is the dose that was approved of the fluocinolone implant compared to the sham control group. Now, obviously, sham control isn't going to get better. These are eyes that were treated essentially with bevacizumab. And you can see when it was less chronic, both groups did equally well. And if you look in the chronic group, you can see that the steroid implant did very well. It looks like it's a bigger number, but statistically, this blue curve here and these two curves on the left are identical. No statistical difference. So don't worry about the numbers. What was different statistically, though, was the sham control group in the chronic disease eyes, those with chronic diabetic macular edema. Again, they were largely treated with bevacizumab, and they had a poor response. So again, they were more chronic, they had had the disease longer, and they were getting VEGF inhibition, which was taking care of that part of their problem, but they were not getting, they were not being able to be treated for their inflammatory mediators, the other ones, because VEGF inhibition doesn't do that, and they had a poor response. Steroids are effective at treating both types. You can see here, but both when there's VEGF alone and when there's VEGF plus inflammatory mediators, one could argue. The more chronic the disease, the more the other inflammatory mediators, the less chronic the disease, the more the VEGF balance. And in fact, there's more data to support this hypothesis. If you look at RISE and RIDE, the pivotal trials that led to the approval of ranibizumab for diabetic macular edema, again, we're used to these fantastic curves. Again, it took monthly injections, but wonderful visual results. But what I'm interested in is the sham control group. For 24 months, we gave sham injections. Horrible. We hated doing that. There's no other approved therapies. It was part of the trade-off of being in the trial. It was necessary for approval. It was mandated by the FDA. But finally, after 24 months, when we'd essentially allowed the disease to become chronic, and we finally were allowed to cross them over and give them VEGF inhibition, to give them ranibizumab, what happened? Nothing. They basically gained no letters. They were no longer sensitive to VEGF inhibition. Or to put it this way, even though the VEGF levels were presumably lowered in those eyes, potentially the argument could be is that the other inflammatory mediators were so prominent because of how chronic the disease was that reducing VEGF was not treatment sufficient to treat these patients. And this was true both in RISE, and there's more evidence to support this hypothesis from the RESTORE study. This was a PRN study, what are called real-world studies, but they're really more like mandated PRN studies. But as I mentioned, 28 to 30% three-line gaiters. The other rule of thumb is typically they gain about 7 or 8 letters, and in fact, 7 or 8 letters were gained in that study. But what is more important and more interesting is the control group, the sham control group. Now, the crossover happened after 1 year instead of 2 years. So what happened after 1 year? There wasn't no response. There was a slow response that took 2 years to catch up, but it was blunted. If you look at the slope of the curve here, after a delay of treatment of 1 year compared to the slope of the curve here when it's treated immediately, this is a much more responsive group compared to the same group that was delayed by a year and then treated. So already within a year, the chronicity of 1 year was enough to show that there was a blunted response to VEGF inhibition. Again, argument could be said, there may be other hypotheses to explain it, but everything I'm showing you is consistent with if you lower VEGF levels, you've done a good job, but if there's a lot of inflammatory mediators, VEGF lowering will not help, and so something else needs to be done for those eyes. That's why they're not responding. That might be why a third of our patients are not responding to VEGF inhibition. It's because of all the other inflammatory mediators, and we know that steroids can control those, but VEGF inhibition only takes care of VEGF. It's a single bullet, which is usually what we want, but not necessarily in this case. In this case, we prefer the broad approach. So again, this is a powerful image here. After 1 year, there's already a lot of VEGF, non-VEGF mediators. It might be even sooner as a result. We've not looked at 6 months to see what would happen crossover. Presumably it would be a little bit better than this, but not as robust as this. So when a patient presents themselves, if they've been coming in for proper screening on an annual basis and you can get in early, you would expect a robust response. But I know in my clinic, and maybe here too, many patients show up out of the blue with no prior exam and bad macular edema. That's already suggestive of some chronicity. They didn't get that overnight. And that suggests that many of those patients may respond to VEGF inhibition, but many may not respond adequately. They may need more than that. So let's take a look at how to decide. So where I veer, as I mentioned earlier, from many American retina practitioners is that I'm more willing to consider switching. But how do I know when to switch? What should I do? And I think there's a lot of data, once again from the DRCRnet Protocol I, but the so-called early study, the early analysis. It was just a post hoc analysis of that data. And it was sponsored by Allergan, so I want to acknowledge that. But a lot of us looked at this data carefully and signed off on it. We felt that this was an accurate representation of what was observed. And so what they did was, in that study again, there was 4 groups, only talking about the ranibizumab groups. There was, they all got an injection of ranibizumab, 0.5 milligrams at time 0, at 4 weeks, and at 8 weeks. And then they came in at 12 weeks, 1 month after their first 3 injections. And then they were analyzed, as they were at every visit, but in this analysis, and they were put into 3 groups in this post-hoc analysis. Those that were poor responders that had less than 5 letters gained at week 12, 1 month after 3 injections, 3 monthly injections. 40% of them were in that group. That sounds about right, about what we're used to, 35 to 45%. 23% were the mid-group, in green, 5 to 9 letters gained, and about 37% were the robust, greater than or equal to 10 letters gained. And then what they did is they put them in each of those bins and then followed them for 3 years to see what would happen. Would they cross over? What would that group do as a whole? And what was seen was these so-called swim lanes, that if you were a poor responder in the early going, you were likely to stay in your group. You can see the error bars. This was about a 70% predictability. Only about 30%, actually 29%, 28.9, crossed over from the red group to the blue group. The reason that the analysis was done from the red group to the blue group, first of all, the blue group is what we want our patients to be, but also many people in the red group had gained 3 or 4 letters, and they only need to gain 1 letter more potentially to be in this group, and that's not so interesting. We wanted them to go from poor response to a good response. So this ability to cross over from here to there was only 30% or less after 3 years, and before that, it was very slow. Only 10 or 15% in the first year, another 10% in the second year, that kind of thing. So you really had to keep waiting, and most of them never succeeded. Most of them never got the good result we wanted. So that tells me that I don't use that as a rule of thumb to say it's 3 injections and I make my decision. But after 3 injections, I look carefully. I personally like to get OCTs at each visit so I can see what the response was to each of the first 3 visits, to see was there a 20% reduction in excess macular thickness after the first injection, another 20% reduction after the second, and another 20% after the third. I'm pretty happy. It's not yet dry, but the trending is very good. I'm going to keep doing what I'm doing. However, if it's only a 20% reduction after the first visit, and then 0 after the second injection and 0 after the third, and I've only reduced 20% after 3 injections, I'm not very happy. I think that's an eye that I would consider switching sooner. But like everybody else, I'm a little bit, I have busy clinics like you do, probably even busier here. I talk to the patient at that visit usually, and then I set the stage for maybe 1 more injection, and I bring them back, and I say, okay, we've talked about it now, let's consider the steroid implant. And again, when I should mention, I use, because it's covered in my case, and I know that there's financial considerations here, for me, fortunately, in the healthcare system that I live in, everything is pretty much well covered with limited co-pays by the patient, or if there is a copay that they can't afford, typically there is a program to cover that for them, so that it ends up being essentially free to them. So I tend to use a lot of Eylea. I think Eylea is the best of the anti-VEGF agents, even though some I do start on bevacizumab, but I usually use most of my patients on aflibercept. And when I use a steroid, I tend to use Dex implant because I think it's the safest in terms of the intraocular pressure control. I think that's the easiest one to manage in that. So I'm more willing to consider switching, but even then I would say I don't always switch after 3. It depends on the circumstance, but between 3 and 6 injections gives me a lot of information to be able to make a coherent decision. And based on this study, it allows me to say that, not to think, well, if I just keep doing what I'm doing, eventually it will turn out. I don't believe that because there's data to suggest otherwise. So I'm more willing to switch, but again, I'm not adamant about switching. It's not black or white. Do it at after 3 injections. But it's a number between 3 and 6, typically. And this was, by the way, this is on vision, but it was also shown true for OCT thickness. So again, the DRCR protocol, I am mentioning this a lot. This again harks back to these PRN studies. What was seen with ranibizumab, 28 to 30% 3-line gainers, as I mentioned to you earlier, that we saw from that steroid study as well, the fluorescein implant. And in this one, you can see that triamcinolone was doing okay, but tailed off because it developed cataracts and IOP elevation, and that study didn't allow you to re-inject a lot of times, so it never caught up again. And this was laser, just to give you a sense of what laser does over time. But what was interesting, and the only subset analysis that showed any significant difference from that finding was in the pseudophakic patients at baseline. So if you take the cataract completely out of the calculus on a pseudophakic patient, you see that triamcinolone was just as good as ranibizumab. One was with prompt laser, in orange, and in turquoise with deferred laser, but it was just as good as them with many fewer injections. But of course, as I mentioned, all these clinical trials have the same thing in common, the PRN studies. We know that the monthly injections do the best. But then comes the family of PRN studies, Restore, the fluorescein implant, DRCR Protocol I, and others. All of them show about the same thing, 28 to 30% three-line gainers, 7 to 8 letters gained in the first year. The one exception to the rule that I don't deny, I accept, I use it as I influence my protocol, my management of patients, but it's an anomalous finding. It is better even than monthly injections, so there's something unusual about this data set, but that's the DRCR Protocol T. And again, what we saw, 13.3 letters gained after 1 year, 12 months, more than what we saw in Vista and Vivid for far fewer injections, and again, a statistically significant improvement here over bevacizumab, but not over ranibizumab in the full cohort. And again, what was important, though, was the subset analysis. And the subset analysis is more consistent with what we normally think about, meaning the 7 to 9 letters gained, and there it is, for those with better vision, 2032 to 2040. What was shocking was how good the patients that had 20/50 or worse vision did in this study, with, again, at 1 year, aflibercept being statistically significant better than ranibizumab and bevacizumab, but by year 2, ranibizumab had gotten enough close that it was no longer statistically significantly different than aflibercept, but aflibercept was still statistically different than bevacizumab. So in my practice, I think that there's a benefit from switching from bevacizumab to aflibercept or ranibizumab, though I don't use as much ranibizumab. But I don't think there's a lot of benefit to switching between ranibizumab and aflibercept. So that's not something I do. If I were to start a patient on bevacizumab and there was a suboptimal response, I would consider switching to either aflibercept or ranibizumab. But if the patient was already on aflibercept or ranibizumab, I don't find any particular benefit to switching around. That's when I would switch to another class of drugs, i.e. steroids. So steroids, this study, again, not to criticize Allergan, but this Mead study, their pivotal trial, was very poorly designed. They were insistent that this drug delivery system released drug over 6 months, which I actually did the pharmacokinetics on and published, and it does release drugs for 6 months, dexamethasone, but at a sub-therapeutic level. It's therapeutic for about the first 3 to 4 months, and then because it's water-soluble, it very rapidly leaves the eye. I discussed that in more detail this morning. And so it tends to be an effective agent for somewhere between 3 and 5 months in diabetics. Now, it is true that in uveitis patients, which is a primarily inflammatory disease, of course, maybe those much lower levels that are seen at 6 months may be enough to treat some patients. So you could get 6-month effect in uveitis, theoretically. But in diabetes, it can happen, but it's pretty rare. I think of this as a 3 or 4 month, typically a 4-month drug delivery system. That's my most common re-injection time. But in this study, you were only allowed to inject every 6 months. And so what was seen, instead of getting the 28 to 30% three-line gainers, only about 20% three-line gainers. It underperformed, but that's the clinical trial actually it got approved, but it didn't convince many of us to use it. I think this is why there was a very slow uptake in the United States. These results were underwhelming, but other places used it more because they understood the flaw of the study design. And in fact, if you look at the DEX implant real-world outcomes, and these all tend to be papers out of Europe, in fact, what they have consistently shown in these many, and I'll go into detail of a couple studies, 2 to 3 injections over the first year with 6 to 9 letter gains, and that's what the PRN studies for anti-VEGF therapy show as well, meaning not 2 to 3 injections, but 6 to 9 letters gained, 7 or 8 letters gained. So let's look at a couple in detail. Escobar Barranco, published in 2015. This had 76 patients, 40 that had been previously treated with anti-VEGF, and 36 that were treatment naive. Those that had never been treated before, naive, gained 12 letters, and those that had been refractory to anti-VEGF gained an additional 8 letters. and the median time to reinjection in those patients was 4 months. That feels like my patients that I use this on. Again, when I tend not to use it as first-line therapy. I tend not to have many patients that are treatment naive. Most of my patients are refractory, didn't respond that well to anti-VEGF therapy, and I tend to get a number of letters gained, and I tend to re-inject after 4 months. So this resonated with me. This felt like something that I would have experienced. The next study was the RELDEX study that was the International Retina Group that was done all over the world by a group of retina specialists. They had 130 eyes. You can see here the number. And again, they had both treatment naive and refractory, and almost identical to what was seen in the prior study. 11 letters gained in the treatment naive and 7 letters gained in the refractory. Again, after a 24-month period of time, you can see this. And in fact, there's a lot of real-world results now that have come out, a lot of studies that are coming out. Here's a list of them with studies going out to 36 months. And there's a lot of information on here, but what do they gain in that same 7 to 10 letters gained? They are very good at drawing the retina. What's also interesting, if you look at the IOP increase, different than the MEAD study, which showed about 40% of eyes ended up being on some type of treatment for IOP elevation. If you look at it, if those that had 10 millimeters of mercury or more, it was all less than 15%, less than 20% in all these studies. The RELDEX study had the highest number, but it went out for the longest time, 36 months, which is a good length of time, still under 20%. With all the DRCRNet studies and the other studies that use triamcinolone, that number that when you go out that far, the Geneva study, et cetera, that's about 40%. I'm sorry, not Geneva, the SCORE studies for CRVO and BRVO. If you look at the DRCR protocol eye, it tends to be about 40% have elevation of IOP versus 20% with the DEX implant. Quite a bit safer. And again, if you look at the Beverdick study from, again, Australia, two things. One is that this showed it was comparable, particularly in pseudophakic eyes, bevacizumab DEX implant. It was comparable on all eyes. But what was also important is that lipid exudates cleared more readily with the DEX implant. And that might be one of the measures of chronicity. We just don't know. And again, you can see how effective this is. I think one of the flaws of the Beverdex study, they could have done even better, is that they weren't allowed to treat as needed. They were treated after 4 months. Some eyes need it sooner than that, and that's why they got these spikes up and down. They weren't being treated aggressively enough, but you can see the drawing is more effective with the DEX implant than bevacizumab. And in fact, the clearance of the hard exudates is better. And here's an example, not from that study, but courtesy of Jay Chablani from LV Prasad, of how it looks clearing. This is just after 6 months. We certainly have eyes where all the exudates cleared entirely. Another important study was last year as a meta-analysis of over 3,800 patients, looking at various studies where what these studies had in common was that everyone in the study had gotten at least 6 anti-VEGF injections, and then patients were either switched over to DEX implant or were kept on the anti-VEGF therapy to see what's the right approach after 6 injections. And what this showed was in every single study, every one of them favored the DEX implant. Well, a couple crossed over the line, so these two may have not been statistically significant, but essentially all of them were on this side of the line. Not a one of them favored anti-VEGF therapy, meaning if after 6 injections in all these studies, almost 4,000 eyes, all those studies showed that the better solution was to give a DEX implant after 6 injections if the response was suboptimal, and in no study did it ever show that continuing anti-VEGF therapy was the preferred option. Now there's also combination therapy, as I discussed. Earlier today, I alluded to it this morning, but as I presented the data, if steroids are wonderful at treating the other inflammatory mediators, and maybe so-so for treating VEGF itself, and VEGF inhibition is fantastic at reducing VEGF levels, then it would be rational to do combination therapy, which I actually don't do very often. That's my 3rd-line therapy. But I gave a course at Academy now, I think 2 years ago, with Jay Duker, and he said that, in fact, he uses combination therapy in many patients. He's a very smart man. He's a more aggressive approach than I do. I feel like I'm getting good response from my current choice between monotherapies. But so the Protocol U was designed to look at combination therapy. But it was a flawed study, mostly because it was meant to be longer, and it was meant to have a study in pseudophakic patients. But they had difficulties enrolling it, and so there was this long run-in to try to weed out patients, and then patients were treated. And what was shown, because many of the patients were phakic, is that there was no difference between the groups, between ranibizumab and combination. Sorry, I don't know why this didn't come out here. Right, between ranibizumab and combination, and that's what we all learned from it. But there was two important other additional pieces of data. One was that if you look at the pseudophakic population, there was a separation of the curves, but statistically it was not significant because it was underpowered. And in the phakic population, it was the opposite, that the combination group did worse. Number one. Number two was undeniable, and what we see time after time when we're treating with DEX implant, how effective it is at drawing the macula. It is really case after case after case. Even the eyes that I thought were sort of okay, but I was tolerating, but eventually I decided to switch from anti-VEGF to DEX implant. It was the first time that those eyes ever were completely dry. It's really quite remarkable how effective it is at drawing. And again, I just as a highlight, the fact that many of these patients are quite ill. Not the little old lady who's coming in, who's, as I mentioned this morning, the 90-year-old who's likely to outlive every man in this room, because we all die younger than they do. But they are 45-year-old diabetics. They are the sick ones. A, they have diabetes. B, they have diabetic macular edema, otherwise we wouldn't be treating them. And that already means that they have a lot of other illnesses compared to other diabetics. And they already have a lot of healthcare visits. So there's two responses to this. They're already coming in too much. They're struggling. They also typically are working or trying to work. It's a challenge for them, especially when they reach the level of diabetic macular edema. These are our sickest patients. Also, Bob Avery from Santa Barbara did a careful meta-analysis now a couple years ago, 3 years ago I guess now is the date, looking at RISE, RIDE, VISTA, and VIVIT, the pivotal studies that led to the approval of Eylea and Lucentis. And he looked carefully at all the causes of death in the treatment groups versus the control groups. And statistically, there is all-cause mortality increase, cerebrovascular accident increase, vascular-related death increase, and arteriothrombotic event were all increased compared in the anti-VEGF group compared to the sham or laser treatment group. Now, I kind of dismiss this. I like to think that I've never killed any of my patients. But this is our sickest population. I think in the AMD population, yes, they have a risk of stroke, but they tend to be, it's with much larger sample sizes, we've never been able to find a statistically significant difference. This is a much smaller sample size, and it came out. And if there was going to happen in a population, it would be, this is our sickest population that is getting a lot of anti-VEGF injections. So historically, for example, with my AMD patients, I would say that if it had been 3 months or more ago, I would be happy to re-inject, stroke or heart attack. With my diabetics, I was doing the same thing. Certainly a month, I start off the month, and I went to 3 months, but now I'm wondering if they're already diabetics, and they have diabetic macular edema, and they've ever had a stroke or a heart attack, and there's an alternative option, which is steroid, DEX implant in my hands, maybe triamcinolone, depending on who's using it and who's paying for it. Again, I don't know why, so I'm less and less if they have any history of myocardial infarction, any history of cerebral vascular accident. I'm not sure that I'm as comfortable giving anti-VEGF as I was in the past. I don't want to be extreme. I'm still mulling it over, but I'm mulling it more actively in my mind. I haven't yet decided where I am. Again, as a final comment, just to mention that we do a lot of vitrectomies on our diabetics, and then what to do, because we know that the half-life of intravitreally injected drugs is much shortened after vitrectomy. So yes, Eylea or Avastin, when injected in a vitrectomized eye, can be effective, but its duration is much shorter. The DEX implant, and it's probably true, I published this paper and did the analysis, but it's probably true of the Iluvien implant too. Any drug delivery system that's a pellet where there has a reservoir, the pellet becomes the reservoir, not the vitreous. And so if you measure, so it doesn't matter how much drug is in the vitreous, it's how much is in the retina. If you measure retinal levels, and this is in rabbits, vitrectomized versus non-vitrectomized, it's basically the same. I think in real life it means that there's the half-life of drugs of VEGF in a free form injected into a vitrectomized eye is much reduced by at least 50%. It's probably reduced by a quarter or so in a pellet, in a drug delivery system. So it's not nothing, but a 4-month device might become lasting 3 months or something like that. So I'll close with a case. Again, a 65-year-old female, right eye with proliferative diabetic retinopathy, status post-PRP with regression. The left eye with severe NPDR. Bilateral diabetic macular edema, much more in the right eye than the left eye. The right eye has already had focal laser, and the right eye has already had bevacizumab 3 times to introduce you to this patient. And this is what it looks like after 3 bevacizumab injections. So that's a pretty bad response. I don't know what it looked like before. This is case that was loaned to me from a course I taught. But then this person got an additional 3 more bevacizumab injections. Now, I probably would have switched at this point to aflibercept, but they gave an additional 3 bevacizumab injections, and this is what it looks like down here. This is pretty close to being a non-responder. So what did they do? They switched to Dex implant. Now, one could argue that maybe this patient should have gotten aflibercept first, but I would, again, my approach would have been, let's pretend for argument's sake 3 bevacizumab injections got us here. Then the next 3 injections were aflibercept, and it did this. That would be, to me, an absolute indication for a Dex implant. So a Dex implant was given at this point. Meanwhile, the left eye has had some disease that's getting more active, so it certainly needs some treatment. So they did something differently than what I would do. First of all, let's look at the right eye. Dex implant given 1 week later, 4 weeks later, 11 weeks later. Look at that drawing. An eye that looked like this after 6 bevacizumab injections, and look at what it looks like after the Dex implant. Fantastic. And this is nothing exceptional. I see it time after time after time. This is, in fact, expected. In fact, I'm disappointed if it doesn't come out like that. This is what I expect from this. Now, the left eye, they made a decision. It had progressed. There was an authorization requirement, but they decided to skip bevacizumab entirely. They said the right eye didn't respond. Let's go straight to steroids. So it was treatment naive. And what was the course of disease there? Dex implant was given. 1 week later, 8 weeks later. Beautiful drawing. They skipped the whole step of getting bevacizumab. So this is an interesting case to show what can happen both with resistant to anti-VEGF and treatment naive. Great responses with the Dex implant. So a couple of closing slides, this one and then a final slide of what I do, and then I'm glad to address any questions. So both steroids and anti-VEGF agents are effective for DME. In the real world, trials results are comparable, but there's fewer steroid injections given. And it's important to note a prolonged delay in initiation of therapy, such as chronic diabetic macular edema, except we don't know how to define it. We struggle with defining it, can limit the anti-VEGF response. How do I know that? I showed you the data from the sham control group of Rise and Ride and the sham control group of Restore that show limited response to anti-VEGF therapy. I also showed you data that says that Dex and fluorescein implants work both early and late from the FAME study as well as from the real-world trials with Dex implant. I mentioned to you that steroid implants, and I think it's true of both, the fluorescein implant as well as Dex implant, are equally effective in vitrectomized versus non-vitrectomized eyes, or at least the impact of vitrectomy is minimized because the drug is living in the implant. I do feel very strongly, after having managed many, many patients with Dex implant and many patients with triamcinolone, that the steroid-related ocular side effects are easiest to manage with Dex implant, particularly IOP. Largely it's because of the pharmacokinetics. Its peak release is at 60 days, it's still therapeutic at 90 days, and tails off. So what I typically do is at the first injection, I bring the person back after a month. If the pressure is 25, I'm going to treat that because I know that by month 2 it's going to go up even higher because the release of the Dex is still going to rise. But if I brought them back after month 2, let's pretend I skipped month 1, and at month 2 the pressure was 25, I might not treat if it was a healthy optic nerve because I know that very soon the drug levels are going to drop and the pressure is going to come down by itself because dexamethasone is water soluble and it leaves the eye very rapidly, for better or for worse. It's one of the advantages in a certain sense, even though it limits its durability. So again, the management is much easier. It's also very predictable. I, like many of you here that have used a lot of triamcinolone, I've had eyes whose pressure got way out of control, even downstream, long after the drug was gone. You can have pressure problems here. I've never seen it. First of all, you only see a pressure problem on the first or second injection. It's much more likely to happen, not over the third or fourth. The longer you give the injection, the less likely it is to have a problem, whereas triamcinolone, we know that it mounts that risk. Again, cataract, when it happens at a lower rate, but when it happens, I do surgery. Though I will say, as I mentioned this morning, that cataract surgery, having a Dex implant on board either 2 weeks before or 1 week before or on the day of, helps control the inflammation and the macular edema that can be precipitated by cataract surgery much more effectively than anti-VEGF therapy. So even eyes that are relatively stable on anti-VEGF at my institution, we like to put a Dex implant in around the time of cataract surgery to prevent worsening of macular edema, to control the postoperative inflammation. So that's a very common usage in my institution. And again, most patients benefit from steroid therapy, but something like 40%, could be as low as 25% depending on the population, but somewhere around 40% are non-responders or suboptimal responders to anti-VEGF therapy. We've seen that from the DRCR protocol I and other studies. So this is my last slide. So what do I really do? Again, I typically initiate therapy with anti-VEGF injections. First of all, I talk for a long time with the patient. I discuss the need for regular visits, particularly in the first year. If we can get ahead in the first year, we can really make a difference in the patient's life. I also discuss the importance of systemic management. I talk to them about their hemoglobin A1C. The worse their A1C, the more worried I am about how they're going to do and how chronic their disease may be, and I encourage them to work with their endocrinologist, their internist, to control their A1C. I also talk to them about blood pressure and their lipid levels, particularly I ask them about cholesterol. People tend to know what their cholesterol levels are, or encourage them to learn this. I do have some systemic safety concerns. I don't know where I am right now, quite honestly. I think I'm becoming more conservative. I'm more worried that I may have inadvertently hurt some patients. I consider deferral of anti-VEGF therapy or initiate steroid therapy if there's a recent cardiovascular or cerebrovascular event. But I think more and more, if they've ever had one, I think to myself, why should I put anti-VEGF therapy into their eye when I can use steroid or potential laser? We didn't really discuss laser, but I don't use that much laser, except I love it when there's focal leakage. If there's a sursinated exudate, I'm so happy to put laser in that eye and avoid the whole trap of pharmacotherapy. However, if it's diffuse macular edema, I rarely put in grid laser anymore because I worry about the long-term effect of those laser spots. Chronic DME may show a limited response to anti-VEGF therapy, but I don't really know what that looks like. We suspect it. There's drill on OCT. There's exudates maybe, but maybe. Who knows? They came in from the street with never had any treatment and they have bad macular edema. All that probably suggests chronicity, but I'm not sure. So I'm an empiricist. What do? I try them with anti-VEGF therapy. But I know that there are eyes that I'm worried about are chronic that are less likely to respond to anti-VEGF in my mind, so I'm very critical. I worry about them, and after 3 injections, I look carefully and critically to see if I should switch them to steroid therapy, or if I start them on bevacizumab, I switch them early to aflibercept, typically, or ranibizumab, and I am very critical then, and I'll switch them even more rapidly to steroid if I don't see the response I want. So again, I don't know what's chronic, so I test them out by giving them anti-VEGF, but I limit the course of anti-VEGF therapy. And again, when the response is suboptimal, as I've mentioned, after 3 anti-VEGF injections, I consider alternatives. I may say it's suboptimal, but in fact, I've reduced each time 20%. I'm going to keep doing it. I'm still suboptimal, but the trend is looking good. So those I would keep doing. But if I've plateaued, if after 3 injections I've not gotten what I want and I can see that I've kind of plateaued, then I will consider switching. And again, since I tend to start with aflibercept, I don't think there's any benefit to switching from aflibercept to ranibizumab or to bevacizumab. So then I would switch right away to steroid implant, to dex implant, because I think that's the one that I'm most likely to manage well. But if it was bevacizumab, then I would try probably up to an additional 3 injections of aflibercept or ranibizumab. And then I would, if I'm still unhappy with the response, I would then consider switching to the dex implant, which is my typical steroid that I use. And finally, I consider steroid therapy implant early if there is a recent MI or stroke, or maybe any MI or stroke. I haven't updated the slide, but I'm sharing my thoughts with you, but it's still an evolution. Or if it's a vitrectomized eye, or in a pseudophakic patient, or particularly patients that are unable to come in monthly, because the way that I manage them, the first dex implant injection, I bring them back every month, because I want to know what the IOP, intraocular pressure, is going to be doing, and I want to know how long it takes to recur. But if let's pretend it recurred at 4 months and their pressure was fine throughout. So now the second time I'll bring them in 2 months later just to make sure there's no intraocular pressure spike, because that's going to be the peak level of intraocular pressure. And I'll bring them back again 2 months later at 4 months, potentially to re-inject them. Then by the 3rd injection, I just probably bring them back 4 months later, and they're very happy about that. So again, that would be my management in an idealized case. Now every case is different, so it might not be that pattern, but that's sort of the process. They certainly don't routinely need to come in monthly after the first injection, which I do see them monthly, so it is an option. There are other categories that could be, if somebody was pregnant, I would not want to ever give anti-VEGF, even though it's been inadvertently done, maybe by some of us here. I hope that none of us have, but we never know. People are pregnant and don't realize it, and then it turns out that we gave them anti-VEGF. Fortunately, it doesn't seem that any fetus has ever been harmed, but certainly none of us would willingly give a pregnant woman an anti-VEGF injection. I would either consider deferring therapy until the baby's born or consider a steroid implant, but of course I'm hesitant in a younger person. I don't want to cause cataract, et cetera. So again, these are the sorts of patients I would consider either first-line therapy or very early switching if they met any of these criteria. And there has been a treatment algorithm developed by Euretina that I won't go to in detail, except it's now been made available and published. And again, it shows the complexity of the decision-making process more than anything else. And there are certain areas where the Euretina people have decided that corticosteroids is a recommended first, depending on how they've done overall, history of, and again, I embrace this notion. This is part influenced me as well. Many of my friends are on this panel. History of major CV event. Not recent, just history is enough to say use corticosteroids first, and I don't disagree with that. I'm not sure that I'm doing this yet, but I think it's now entering more into my thought processes. And so this is a useful type of algorithm that you can all look at if you choose to at a later time point. So with that, I'll close, and thank you for your attention, and be glad to address any questions. Thank you.
Thank you very much, Dr. Cooperman. That was wonderful. We tackled a very, very complex subject with, where there are a lot of decision making on a daily basis. Before I open the floor to questions, I have two questions, please. You alluded this morning that the dosage that was used, or the type of triamcinolone that was used in the protocol I, was not the same triamcinolone that we have.
That we're used to here in real life.
And that I seem to have understood that it is maybe not as effective or it doesn't stay as long. So I'm going to play the devil's advocate here.
Sure.
Had it been the triamcinolone
Kenalog.
would it have been a better result?
Well, I think yes. I do think that Kenalog, Kenacort, of all the triamcinolone formulations, and one of my parts of my talk I gave this morning was a study that I published in Retina a few years ago, where I compared the various formulations of triamcinolone, and I showed in that study that Kenalog, Kenacort was far superior in terms of durability and therapeutic benefit in terms of this animal model I use of VEGF-165. So I do think it is the best of the triamcinolone formulations. Not every triamcinolone formulation is the same. But what I still do have concerns of with Kenalog, Kenacort, is the side effect profile. The intraocular pressure is a continuing cause of concern. And also, the cataract formation is much more prominent in my mind compared to Dex implant. Again, I have the advantage in my population where insurance covers all these costs. So cost is, and I understand that here, cost is a factor. So once you factor in cost, the answers may change. But if you were to take cost out of the equation, that's why I'm able to use aflibercept as my first-line choice, and why I'm able to use Dex implant as my first-line choice of steroid, because I think the side effect, I think the durability of Dex implant and Kenacort are likely to be comparable. They both last somewhere around 3 to 4 months or so. Maybe Dex implant is a little bit longer, but Kenacort, Kenalog lasts something like 3 months. The other formulations only last a month or at most 2. So those, I think, are effective for that period of time, but it's a much shorter period of time. Kenalog lasts in a durability that is slightly less, but maybe comparable to Dex implant. But the side effect profile, particularly the intraocular pressure management, is far more extreme. I've had many eyes that have needed surgery, eyes that months after an injection suddenly develop IOP elevations. I've never seen that with Dex implant. But I think you're right. I think that the steroid groups, the triamcinolone groups in those studies, that was also true of SCORE, the first SCORE study, and the DRCR protocol B and DRCR protocol I all used this formulation of triamcinolone that had a very short half-life.
I have another question, please.
Sure.
Since I don't have a very long experience with Ozurdex, I mostly use anti-VEGF. Does the effect wane off after a while? Let's say you've given 3 or 4 or even 5 implants. Does the effect wane off? And for those who have used this for a long time, and we know that it dries it very nicely, but has anybody looked on the OCT whether the quality of the dryness was different between steroid-treated eyes and anti-VEGF-treated eyes? Is there more drill? Is there less drill? Is there more ellipsoid loss? What happens structurally? Because dryness does not always correlate with vision, as you know.
Correct. So let me deal with the frequency of injections. It's a little bit all over the map. I found that there are many eyes that need less injections of Dex implant over time. Most eyes you still get a good robust effect as you keep giving it. It's very rare for it to attenuate the response over time. There are some eyes, however, that I give a series of injections and suddenly I don't have to give any more injections. More common, you have to keep giving, but there's still a good response. In terms of the quality of the dryness, that's a complicated question because in my hand and many others, most of the patients worldwide are getting DEX implant that have had refractory response to anti-VEGF, a suboptimal response to anti-VEGF. And what that means is they've been wet for a long time. So unfortunately, I'm guilty of the same thing. I waited too long. I give the DEX implant, the back of it dries beautifully. I have a pretty picture. Well, I have a pretty picture with one exception. It's beautiful looking. Vision doesn't come back as much as I want. Why? If you look at that ellipsoid zone, there's photoreceptor loss. I've waited too long. So that, and anybody who practices uveitis, we hate those macular yo-yos, as we call them, because we know that that's damaging the photoreceptors. So we kind of did our patients a disservice by waiting too long. So even though we get good drying, we don't always get that good vision because it wasn't used early enough to get the good drying when we still could really rescue those photoreceptors. So it's almost an unfair analysis. You'd really have to look at the quality of the OCTs for treatment-naive patients in a randomized controlled trial, looking at drill and other endpoints that one could argue of an anti-VEGF treated group versus a DEX implant treated group. And to make it be fair, probably to keep the analysis more interesting, maybe in a pseudophakic population so you don't worry about the cataract effect and all that, and see what the quality of the drawing is. It's an excellent question, but most of the data is stacked against the DEX implant because we tend to use that downstream after maybe it's, if not completely too late, it's later than it should have been.
So there is a recent report about multiple injections of dexamethasone in patients with pachychoroid can transform them to CSR. So do you have any experience with these cases? And would be the threshold for this shifting to the steroid will be higher in these cases, or?
So again, pachychoroid tends not to be a big problem in diabetes. It certainly can be. And so I understand the conversion to CSR promulgated by the steroids. I've not ever seen it in any of the hundreds of patients I've treated with, or however many patients, nor has it been reported with the DEX implant for the patient population we're using. I think it would again, I tend not to use it for AMD and other conditions where pachychoroid might be more a component, but it doesn't surprise me given what we know about how steroids have a role. Steroids are amazing. Still to date, if you were to be marooned on a desert island and you chose 3 drugs, despite, with all due respect to there's some people from Allergan here, despite the pharmaceutical industry, if you took aspirin, penicillin, and prednisone, those would be as good as any 3 that you could choose today. So steroids are great, but they do have their side effects.
Thank you, Professor Kuperman, for this really nice, informative talks. I believe that DME is multifactorial in origins. It's not just only assigned to one pathology in regard. And I think so the best approach by the time being to have combinations of the treatments, including the steroids plus the anti-VEGF. Although that anti-VEGF maybe the effectiveness as anatomical restore of the contour of the macula is not really is good as anti-VEGF as we know. But looking for the patient who's having multiple injections of anti-VEGF, they found that the progressions of diabetic retinopathy is really retarded and less than. And this is one of the benefits that we have observed over the previous and been documented by the DRC units. So looking for from the side of DEXA implant, is that could be achieved without using anti-VEGF alone?
I mean, it's a very good question. One of the great benefits of anti-VEGF is what it can do to inhibit progression of proliferative diabetic retinopathy and get reversal. In fact, we've not discussed Protocol S, another important DRCR protocol. Besides Protocol T, I think it's had a big impact on us. But steroids have been shown in the FAME trial to do something similar, but I think that the effect of steroids on proliferative diabetic retinopathy causing regression or inhibiting progression to it is more muted. It's not as strong. I think VEGF inhibition will get a bigger effect for that, and it's not on label for any of the steroids. So I would not, at this point, that's one of the trade-offs. What we don't know still, again, I mentioned focal laser. I love giving focal laser when there's an indication for it. I don't like giving grid laser, but I still give PRP on my patients, even when they have proliferative disease, even when I'm giving them anti-VEGF injections, because I'm worried that disease will recur. I'm worried that the patient won't show up. So what I've done, which is what many people are doing, but we've not really we've all been doing it independently without looking at it in a coherent fashion, is to, instead of giving the 1,500 to 2,000 spots, which does cause nyctalopia, which does cause peripheral vision field loss, to maybe give 1,000 spots, 800 to 1,000 spots. So we know we have some laser in there. Hopefully that's enough in combination with their anti-VEGF injections. Maybe they don't become as anti-VEGF dependent. But it's still an open school of thought. We don't know really what to do with those patients anymore. I think we're going to gradually trend towards more anti-VEGF injections, but it's still not clear that we're really going to trust those patients, especially patients that come in with bad disease. You're thinking, how did they get here to begin with? Why am I going to trust them to show up every month? I'm going to want to put laser in sooner rather than later. So again, it's a dilemma.
Okay. Thank you again for the great lecture.
Thank you, very kind.
I would like to hear your thoughts on 2 points. The first one is sub-threshold laser. Does it fit in any
Right.
in your practice, and the endpoint management? The second point is, where do you see suprachoroidal steroid injections and management of DEB
Sure.
in the future?
Two excellent questions. So I do have a sub-threshold laser, and I use it. It's the Iridex one. It does pattern. It kind of does everything. It does pattern. It does sub-threshold. It's a great machine. I treated a number of patients. I like the notion of doing grid laser because there's no damage, and I'm hoping that 20 years from now there will still be no damage. I do have patients that I personally treated 20 years ago with photocoagulation, the tiny little spots, perfectly done. This is to the young physicians here, that those spots will come back to haunt you because 20 years later they all look horrible. Those little tiny spots become big spots. They fill and they destroy the macula. So I hate doing that type of grid laser, but I like doing threshold laser. I've done it now a couple of dozen patients, and I saw some drying, but I didn't see a resolution of their need to get pharmacotherapy. Most of them are still getting pharmacotherapy. So very few do I truly rescue. So I don't know what the answer is, and that's being looked at by others as well. So it's an open question. Certainly if I do feel that for whatever reason that I'm not getting a satisfactory response, I will add subthreshold laser, but it's not usual that it rescues things. Now, I've already been asked about this morning about sub-Tenon's steroid, and we've discussed that. I think it's not as durable. I don't know it's much safer. It's not as predictable, but it has a role. But suprachoroidal is the first time anybody's asked me that, and that's an interesting approach. I've done a lot of research on it, and I am an investigator in the Clearside studies. I think that needle by Mark Prutzner or something like that of Georgia Tech is a very interesting concept. Interestingly, with a different company based in Irvine, I've been exploring for 5 years suprachoroidal drug delivery, and we couldn't get it to work. There's always been this notion of a suprachoroidal highway. I love the whole concept that you inject a drug anteriorly and it streams posteriorly towards the macula. And we did radioactive trace, we did everything, and we could not show that. We were getting a lot of drug loading up front, and some of that drug would cross into the vitreous and then eventually get to the macula, but we could never show it passing, including steroids, in that down the suprachoroidal highway to the macula. So I don't doubt it. I'm seeing the Clearside results, but I don't quite understand it yet, and we have to see. I mean, that study will be interesting. It's a clever way. The trouble with that is how predictable will it be? We know that we can get the needle into the middle of the vitreous cavity pretty much 99.9% of the time. Every once in a while we might get distracted and hit a lens. Every once in a while, God forbid, every 3,000 times we might get an endophthalmitis or even more rarely a retinal detachment. But the safety record is very high, and we know that we're getting the drug in the eye. The suprachoroidal approach has a higher, there is those stents. Remember that other company that had that cannula, 1 in 100 got a bad bleed. That's a terrible statistic. Now the Clearside doesn't have that complication because it goes in minimally, but how reliably will it get in? I don't know. The clinical trials will tell us, but I worry that that's going to be a less reproducible approach, even though I love the idea of new therapeutic approaches.
Thank you very much. You mentioned that about 20% of patients that received the implant developed some sort of pressure elevation.
Correct.
And my question is, Two parts. How frequent of these patients needed intervention, surgical intervention? Number two, what's the pharmacological changes between the implant, dexamethasone, and the canalog? Mainly, is it a major difference in the molecule to make this less having less side effects regarding the pressure elevation and so on?
So excellent question. So again, I've never had once a case of needing surgery with a DEX implant, though if you look at the literature, there is a quoted rate, but it's well less than 1%, a half of a percent or something like that. It's extremely rare to ever need to have surgery. The difference between those is actually what I talked about this morning. There is actually interesting structural changes, how it affects gene upregulation, how it affects the water solubility, how some of these steroids tend to migrate more towards the trabecular meshwork on the lens. Triamcinolone has been shown to do all those, and dexamethasone less so. So there is a body of evidence that suggests that of all the steroids, dexamethasone may be the safest of them. So it's a bit of a lucky coincidence that that's the one that was placed, because I don't think they realized that when they put that, when it wasn't even Allergan, it was a company that Allergan bought called Oculex, put dexamethasone into that drug delivery system. There's two very clever guys, Vernon Wong and Jerry Jin, that created this, but I think it was somewhat lucky, serendipitous, that they put dexamethasone. It is the least toxic of the steroids, the most water-soluble, the less preferential for the trabecular meshwork, the less preferential for the lens epithelial cell. It somehow is a little different and every steroid is a little different from the others. And that's some of the stuff I talked about this morning.